Welcome everyone to today's webinar. I'm Laura Lubbers and I'm the Chief Scientific Officer of Citizens United for Research in Epilepsy, or CURE. I want to thank you for joining us today. Today's webinar is entitled Fenfluramine for Dravet, an old drug with a new purpose. And it will review the reasons doctors explored fenfluramine as a possible therapeutic option for epilepsy, why it is safe and effective for treating seizures in children with Dravet syndrome, as well as the potential side effects caregivers should know about. This webinar is part of our 2020 Leaders in Epilepsy Research webinar series, where we highlight some of the critical research that's being done on epilepsy. Today's webinar is being sponsored by our friends at Zogenix. CURE's mission is to find a cure for epilepsy by promoting and funding patient-focused research. The topic of today's webinar, the drug fenfluramine, which is newly approved for the treatment of seizures and called Fintepla, acts primarily as a serotonin-releasing agent. Serotonin is a neurotransmitter in the brain, and over the last 20 years, CURE has invested in research aimed at understanding the role of this neurotransmitter and its relationship to epilepsy. CURE funded studies by Dr. Carl Feingold very early on made a connection between serotonin and respiratory arrest in mice prone to SUDEP, or sudden unexpected death in epilepsy. More recently, CURE funded a study by Dr. Roop Sanju, who tested the usefulness of the selective serotonin reuptake inhibitor known as fluoxetine in reducing post-seizure breathing abnormalities in people with epilepsy. Today's webinar explores the role of the serotonergic system in regulating seizures themselves. Our presenter is Dr. Joe Sullivan, who is a pediatric neurologist and director of the University of California, San Francisco Pediatric Epilepsy Center. He specializes in evaluating and treating children with epilepsy, particularly those who do not respond to medications. In addition, he runs a specialized clinic focused on people with Dravet and PCDH19 syndromes, and cares for a large group of children with these types of genetic epilepsies. He's also interested in epidemiology, health services research, and the role of computers in medicine. Before Dr. Sullivan begins, I'd like to encourage everyone to ask questions. You may submit your questions anytime during the presentation by typing them into the Q&A tab located at the bottom of your Zoom panel, and then clicking send. And we'll do the best we can to get through as many questions as possible. We do want this webinar to be as interactive and informative as possible. However, to respect everyone's privacy, we ask that you make your questions general and not specific to a loved one's epilepsy. I also want to mention that today's webinar, as well as all previous and future webinars, will be recorded and are available on the CURE website. With that, I'll turn it over to Dr. Sullivan.
Thank you, Laura, and thank you to CURE for inviting me to give this webinar. It's certainly been a crazy 6 months, but we are moving forward here to continue caring for our patients and develop new, hopefully life-changing therapies. So not knowing who is all dialing in, I assume many of you know about Dravet syndrome, but maybe some of you are looking to learn a little bit more, and that's why you're dialing in. I want to just go over a few slides about what is Dravet syndrome. So this is just kind of a very broad overview. So give me 1 second here. I thought I turned off something, and I know that's, I don't want something to be dinging on my apologies. Okay. All right, so the general definition is that these children, previously normal children, have their first convulsion prior to 1 year of age. Although there's been some recent studies done by Ingrid Sheffer's group in Australia that have really looked at some of these kids with very precise phenotyping, and it is now accepted that there are some children that may present a little bit later, but I think for purposes of this talk, we can assume that the majority of patients will present with their first convulsion prior to 1 year of age. And in fact, usually it's much earlier, usually between 5 to 8 months of age. These seizures are often prolonged. And again, this is sort of the classic phenotype, but don't necessarily have to be. And I think my take home message here is that we really need to start having this on our clinical radar and when to suspect this diagnosis, because as new treatments become available, an early diagnosis and early targeted therapy is going to be key to improve patient outcomes. So they are often prolonged, greater than 10 minutes, and these kids are by definition previously normal prior to onset. So no real other epilepsy risk factors, normal birth and delivery, normal development, normal exam. Then after that first seizure, additional febrile or afebrile seizures occur. And there's been a lot of concern about the association of the onset of seizures surrounding the typical childhood vaccines that are given at 4, 6, 9 months of age. And this has actually been looked at again by the Australian group. And while there are some associations with timing of onset of those first seizures in those that receive vaccines, when you look at these kids over time, the outcomes are overall similar. And so we feel very, very strongly that the vaccines are not causal in any way. And we in the Dravet community really recommend all of the regular vaccine schedule be given to our children, because getting any of these diseases, these infectious diseases, could be more catastrophic than certainly the vaccine themselves. Then in the following years, additional seizure types occur. And again, these typical presentation, skip slide, sorry, it's a little bit glitchy here. Okay, 6 months of age, convulsive status epilepticus. So the majority of these early onset seizures are convulsive in nature. And the classic seizure type is what's called a hemiclonic seizure. So one side of the body will often be in this hemiclonic, this clonic state. And then 2 to 3 months later, another seizure may occur, and may actually occur on the other side. And I would argue that that is a very specific seizure type for these children. And if you have a typically developing child who has 2 hemiclonic seizures that had alternated sides, you almost have your diagnosis right there. And often, you know, these medications that we use very commonly, oxcarbazepine, carbamazepine, for focal seizures, infants, if those are started in a child with Dravet syndrome, it actually can have an exacerbating effect. So the subsequent epilepsy course, basically these kids can have any type of seizures, so polymorphic seizures. And again, even though there's early temperature sensitivity, that temperature sensitivity continues, but they can still have seizures that are unprovoked, so without any associated fever. And those different types of seizures include myoclonic seizures. In fact, the prior term for Dravet syndrome was called severe myoclonic epilepsy of infancy, but that term has now been dropped because not all patients with Dravet syndrome will have myoclonic seizures. And many of us believe that that term, severe myoclonic epilepsy of infancy, may have actually been a barrier to suspected diagnosis, because if a patient's not having myoclonic seizures, why would a very well-meaning, well-intentioned provider give a diagnosis of a severe myoclonic epilepsy? Absence seizures can occur. And then there's this very peculiar seizure type called obtundation status, which I feel is also somewhat unique to the Dravet syndrome patient population. And this is basically the kids start to act a little bit different, a little bit more withdrawn. They may have some myoclonias of the face. They may still be able to eat, but aren't as engaged. They're still able to play, but the parents clearly know something's different. And when you put an EEG on them, the EEG is not a classical non-convulsive status picture, but it looks clearly different from their baseline. And it's a bit still controversial as to how this is best treated. At our institution, we still treat this as a form of non-convulsive status and usually use benzodiazepines. But interestingly, this type of seizure can start after a generalized convulsion, or it actually can end when a convulsion happens. So it's almost like they're in this fog, a convulsion happens, and it's almost like a reset. And then lastly, a significant percentage of these patients do have photo or pattern sensitivity. And I say pattern sensitivity, you might be able to see the shirt that I'm wearing. This would be a bad shirt to wear if I was seeing one of my Dravet patients today, because it's checkered. I have a few patients that will literally get drawn into a pattern, and it doesn't even have to be this prominent of a pattern. Sometimes even a carpet that has a texture, even a wall that has a certain texture can be provoking for these patients. So really a problem for those in terms of their overall quality of life, because we live in a world that has lots of patterns. So moving into the genetics, we're in a very exciting new world now, finally being able to have genetic testing readily available to us. But I still want to highlight that only 90% of patients with that classical phenotype that I just presented to you will have a mutation in the SCN1A gene. So there's still 10% of patients where there are likely other genes involved, or maybe other causes, and it still remains a clinical diagnosis. So just because you get a genetic panel back and there's no mutation in the SCN1A gene, if the patient fits that phenotype that I just went over, don't be afraid to give that child a diagnosis of Dravet syndrome. When you look at the different types of mutations that can occur, about 50% of them are truncating, and another 50% are missense. Most often, the missense mutations are occurring in the part of the gene that codes for the pore forming region, and that's where it translates into the more severe phenotype that is Dravet syndrome. But there are still very poor phenotype-genotype correlations. I think the last I looked, there's over 1,000 reported mutations, and you can have the exact same mutation, but a very different clinical phenotype, both with regard to seizure types, intellectual disability, and overall outcomes. Copy number variants should also not be ignored as an important causal genetic factor for these patients. And then this is sort of the other genes, at least in the literature, that have been described to be associated with the clinical diagnosis of Dravet syndrome. And again, if I haven't said clinical enough, I really want to stress that we really need to have this on our radar screen for suspecting it clinically, because even though genetic testing is much easier to get, don't wait for the gene testing to start thinking Dravet and having that conversation with a family. So as I showed, the seizures, any type of seizure can happen over the lifespan of a patient with Dravet syndrome. And this is a study that was done in Europe by a colleague of mine, Dr. Sullivan, who looked at all of the different seizure types that are present over the age span. And you can see on the left of this figure, this is putting all of the seizure types together, and you can see that tonic-clonic seizures or major motor seizures are occurring in upwards of 80% of patients, with a smattering of all these other different seizure types, again highlighting that myoclonic seizures may only occur in half. And then you can see that these seizures persist over the lifespan, and while there may be some fluctuations in terms of how frequently those occur, even our adults that have Dravet syndrome are still experiencing a high degree of seizure frequency, leading to high mortality, potential mortality, and certainly morbidity. And overall, if you look at these bars here, it was actually seen like what percentage, what is the number of patients that actually can have these 3 months periods of seizure freedom. And the estimate from this study was less than 10% of children, young adults, and adults will actually have a sustained period of seizure freedom lasting 3 months or more. So beyond seizures, and this is something I think that rightfully so is getting a lot more attention now. We certainly, as an epileptologist, we care about seizures, but we care most about how these seizures are impacting the child in their everyday life, and how this is affecting the family in everyday life. And I've often said during talks that even someone who's having 10 seizures a week, they're still spending 99% of their week not having a seizure, right? And that's when they're living, right? They're living their lives. And it's this 99% of the time that they're not spent seizing that is creating a lot of the caregiver anxiety and burden, all the issues that come up related to providing a safe school environment. And these are key. And I think I'm really pleased that some of the recent studies that have been done are starting to look at these non-seizure related endpoints. So unfortunately, even in 2020, with our new medications, intellectual disability is pretty much the norm, with about half falling into the severe range and the other half falling in the mild to moderate. What this translates into practically is no language to maybe the ability to have simple conversation, with only about 10% able to live independently. And even when I say independently, that usually does mean with still some supervision. It's my hope that now in 2020, that a child that is diagnosed with Dravet syndrome, not only because we were able to make the diagnosis earlier, but because we have new and effective treatments, that we're going to start to shift this percentage of intellectual disability more into the mild to moderate range, and maybe even with some disease modifying therapies, make it mild to normal, but that actually remains to be seen. Some of the other non-seizure related issues beyond intellectual disability include ADHD, lots of behavior problems, impulsivity, as well as motor dysfunction that can lead to an abnormal gait and poor fine motor skills, such as poor hand-eye coordination. And this just basically shows how these children start out. On the left of the graph here, the orange is normal, so the majority are normal to maybe mildly abnormal. And then very quickly, by the second and third year of life, you can see that the percentage of these children that remain having a normal developmental quotient drops down to less than 10%. And this has been debated over time as to whether or not this is an actual developmental regression, or is it actually a developmental stagnation and the children are not keeping up with their age-matched peers. And it's now pretty widely accepted that it's the latter, that they still are making forward developmental progress, but not at the same pace that we would otherwise expect. So they continue to fall farther and farther behind. So now getting into the main topic of the talk here. So fenfluramine, why is this even being considered in Dravet? And this is such a great story. And I really want to thank my colleague, Sullivan, who gave me a lot of this historical context as to how this happened, because he is one of the epileptologists in Belgium that really continued to get this story moving and was able to provide us with some of the data to get Fintepla into the phase 3 programs and ultimately approved. So in 1984, Gusteau of Lennox and Gusteau fame used fenfluramine in 3 children. It was known back then that fenfluramine was a serotonin agent. And so as a behavioral medication, he tried it in 3 children with intellectual disability, and this compulsive behavior, which he thought was self-induced fainting, where these patients would either hyperventilate or they would find some pattern or something and actually cause them to faint. Lo and behold, in all 3 of those children, the behavior and self-induction approved. Around that same time, Jean Aicardi, who is an icon in child neurology, also tried fenfluramine in 3 patients, but in this time with self-induced seizures, really going on this sort of self-induction hypothesis. And lo and behold, seizures resolved in all the patients. And the hypothesis at that time was maybe it was because they were no longer self-inducing, right? So you eliminate the provoking feature by improving their behavior, and therefore the self-induced seizure doesn't occur. But interestingly, when EEGs were done on these children, their photosensitivity was also improved. And so he postulated that fenfluramine could have a role as a possible role as an anti-epileptic drug. So then, like all good mentors in medicine, Boll and Cesar, now 10 years later, started to remember. I remember that self-induction, and I have these kids that also seem to be pattern sensitive and photosensitive. And remember, a lot of patients with Dravet syndrome can be pattern sensitive, but they weren't thinking Dravet syndrome back in 1996. So they tried fenfluramine in 11 children, 8 of whom did have this pattern and photosensitivity. And out of those 11 children, 7 became seizure-free, with the other 4 having a 75% reduction. So again, we're kind of building some evidence here that this could play a role as an anti-epileptic drug. And I'm not going to go through everything on this slide, but just to say, if you look at those 11 patients, they all had self-induction. Many of them were photosensitive. And if you look at the age of onset, they're all, the majority of these are in the first year of life. And then if you look at the developmental quotient, the majority of them do have mild, moderate, or even severe intellectual disability. And they all had tonic-clonic seizures, with half of them having myoclonic seizures. And then let's see how they did when fenfluramine was added on. So I'm going to highlight here those patients that actually were later found to have a clinical history. Again, Dravet being a clinical diagnosis. When you went back and took the early childhood history of these patients, lo and behold, it was consistent with a diagnosis of Dravet syndrome, and they were found to have pathogenic mutations in the SCN1A gene. And if you look at these, so the age at what they started fenfluramine was anywhere down to 18 months of age, all the way up to age 15. They were on sort of the usual suspects that we typically use to treat these patients, and that's particularly so back in the mid-90s. And you can see the decrease in seizure frequency here being 100% to greater than 75%, and for long duration. And so that really fast forwarded to another 10, 15 years later, where you can see some of the one of the authors here is Dr. Bol, along with Dr. Lagay and Sullivan from the Belgian group, reported out additional patients who now had a diagnosis of Dravet syndrome, and they could specifically report on the efficacy of fenfluramine. So in this expanded cohort, there were 12 patients, 5 that I'd highlighted in green from that original report. 11 out of the 12, again, upwards of 90%, had pathogenic SCN1A mutations. That doesn't mean that the other 1 did not have Dravet syndrome, they did. And the mean follow-up was 11 years, ranging from 1 to 22 years. Because remember, this was published in 2012, and some of those patients were actually started on the drug, or at least were reported in that original paper back in 1996. And the mean dose here was around 0.34 milligrams per kilogram per day, with a range of 0.1 up to 0.9. And this is very important because just in this observational small study, this really is what served as the dosing guidelines that were used in some of the pivotal phase 3 studies. And so again, not to go through this entire slide, but just to highlight some of the success stories. So everything highlighted here in green are those that actually had 100% reduction in seizures. So seizure free, which for all of you who are on the webinar or who have taken care of patients with Dravet syndrome, or just are learning about Dravet syndrome now, as I showed you in that prior slide, less than 10% of patients with Dravet tend to be seizure free for periods longer than 3 months. So clearly something is going on here. And equally important, if you look at the duration of seizure freedom, this is almost unprecedented in the sense that ranging from 1 year of seizure freedom all the way out to this patient number 3 with 19 years of seizure freedom. And then there's I've given this talk, just the history of fenfluramine in Dravet, and there's these great stories about how fenfluramine became difficult to get, and there was a royal decree from the King of Belgium in order to keep these patients, and some of these patients actually needed to stop fenfluramine, and lo and behold, when they did stop, they did have an aggravation of seizures that was regained once it was restarted. So let's move now to present day. So all of these observations from the initial 3 patients in the clinic to then realizing that maybe this had a specific indication for Dravet syndrome, but they were all open label, non-placebo controlled studies. And for those of us involved in epilepsy research, we know that what always is seen in our anecdotal observations is not always generalizable. And I just remember a quote that the plural of anecdote does not equal data, right? So we really do need well done phase 3 placebo-controlled trials, and that's what I'm going to present to you here. So the fenfluramine phase 3 program, thus far with the publicly available data, there are 2 studies that have been results have been released and been published. Study 1 involved 119 patients, and study 1504 involved 87 patients, and I'm going to get into a little bit of the differences here. The mean age in both studies was about 9 years. The inclusion criteria were essentially identical, except study 1504 required stiripentol, whereas study 1 excluded stiripentol. And the main reason for that was because of the drug-drug interaction that occurs between many anti-seizure medications, including fenfluramine and stiripentol, and so the dose ranges needed to be different. But the number of seizures required to get into the study, you had to have the children had to have 6 or more countable convulsive seizures in a 6-week baseline, so averaging about 1 per week. And as it turns out, the median wasn't even close to this sort of floor, right? These patients are continuing to have a high seizure frequency despite current available medications, with the median being 24 seizures per month in study 1 and 12 seizures per month in the 1504 study. And again, these are not the myoclonic seizures. These are not absence seizures. These are countable convulsive seizures, usually generalized tonic-clonic, focal clonic, tonic, even atonic seizures. Pretty standard epilepsy study design with a 2-week titration schedule, again, blinded, in a 12-week maintenance period. And if you look at the background anti-seizure medications, again, the usual suspects with valproate, clobazam, topiramate, and levetiracetam being the most common, and then stiripentol in study 1504 because it was required, and none in study 1 where it was excluded. Just one comment about that is that in study 1, there still were patients that had failed stiripentol in the past, but they just could not have been actively on it at the time of screening and subsequent randomization. So here's sort of the take-home results from study 1, showing the responder analysis. In the red line here, we have the placebo. In the blue line, we have the lower dose, and in the green line, we have the higher dose. I failed to mention the prior slide, the study 15-1, there was, because of that range that was seen in the Belgium study, where we really wanted to understand if there was, what was the optimal dose and was there actually a dose response. So patients were randomized to either receive placebo, low dose, or high dose. And you can see a very nice dose response here. And I want to really call out to the right of this graph. We see the 75% responder rate. So 50% of the patients that were given the 0.7 milligrams per kilogram per day with a max of 26 milligrams, 50% of those patients had a 75% reduction or more, or 50% reduction, sorry, 50% had a 75% reduction or more. And even in the low dose group, almost a quarter of the patients had a 75% reduction or more. And then what we really, care about is the far end of this graph, right, the right side. And what do we see there? So when you look at patients who actually were seizure-free during the entire 14-week titration and maintenance phase, or who had a single seizure, right? It's really hard in any epilepsy drug study. Once you have a single seizure, you can never, by definition, be seizure-free for that period. So we went back and looked at, okay, what if you just had one seizure? And it turns out 25% of the patients in the low and high dose groups combined were what we termed near seizure-free, which I think we would all agree is almost as good as seizure freedom for a 14-week period of time. And then looking at study 1504, again, there were only a single dose was used in this study that was meant to approximate the high dose of 0.7 milligrams per kilogram. This was the 0.4 milligrams per kilogram. Because of the interaction between stiripentol and fenfluramine, you need to give a lower dose to achieve the same exposure. And so we can see here, when compared to placebo, that 54% in the treatment group actually had a greater than 50% reduction in seizures. And then again, calling out the 75% responder rate, about a third achieved this. And then again, to be consistent, those that achieved near seizure freedom was approximately 14%, again, during that entire 14-week titration and maintenance period. So hopefully we would agree. Those are very impressive results in a already highly treatment-resistant patient population that are already on standard therapies for the treatment of their seizures. So what about safety? This medication, fenfluramine, was part of a weight loss drug program back in the 90s, and it was withdrawn from the market due to concerns of cardiac valvulopathy and pulmonary hypertension. And so this could all have been for nothing if we saw these great results, but it actually had a serious adverse event profile. Before we get into the valvulopathy concerns, we did note that, again, it's noted that this was part of a weight loss drug regimen. And so it shouldn't have come to a surprise to any of us that decreased appetite was very commonly seen in these patients when compared to placebo. But I want to call out that just because they had decreased appetite, that didn't necessarily always translate into clinically significant weight loss. And I can tell you, in the patients that I personally enrolled in these phase 3 programs, that while decreased appetite was definitely seen, most often that decreased appetite got better, maybe never got back to exactly where it was pre-fenfluramine, but got to the point where they continued to gain weight as we would expect a developing child to do. And then if you look at this other sort of laundry list of adverse events and open up any package insert of any anti-seizure medication, you're going to see a lot of these. I'll just call out that lethargy, somnolence, and fatigue was seen, but at a relatively low and extremely tolerable level for these patients. So no big surprises there. But let's get into the valvulopathy, because I think that that's something that everyone who hears fenfluramine and they're like, what? Why would I give a kid with Dravet syndrome that it's gonna harm their heart? This figure here is just showing the FDA grades of regurgitation at each of the 4 heart valves. And what is determined, it was in this definition is what's determines what is an actual valvulopathy. So absence regurgitation, obviously that's a completely normal valve, but trace regurgitation. So modern day echocardiograms have the ability to detect just drops of blood that may squeak past that valve. And it's very widely accepted that that is still a normal valve. So if you have trace regurgitation of any of the valves, that is still considered normal. And that's even true for mild regurgitation with the exception of the aortic valve. So mild mitral regurgitation, tricuspid or pulmonic, is still considered physiologic and normal. And it's not until you get into the moderate or certainly severe that that's actually considered clinically significant cardiac valvulopathy. And so when we look at this in a little bit more detail, when the study was being designed and working with the FDA, and of course with the history of the drug, everyone wanted to make sure that we were doing this right and that we were including patients that had squeaky clean, like clean, absence of regurgitation in the aortic or mitral valve, because those were the valves that were problematic in the fen days. And so anyone who even had trace regurgitation, so again, even though that was considered normal, they were excluded from both of these phase 3 studies, and including the other phase 3 study that is ongoing. And as you can see, this is common, right? Trace regurgitation occurred in almost 15% of patients, Dravet patients that were screened, had all of the other inclusion criteria, but sadly, because they had this physiologic finding that at the time we just wanted to be extra cautious, they were excluded from the study. Interestingly, this is in some of the few studies that have looked at echocardiograms in otherwise healthy children. It's very similar to what is seen in the normal population. So makes us feel comfortable that patients with Dravet are not at a higher risk of having this finding, and also are not at a lower risk, and can be, from a cardiac standpoint, in our opinion, can be treated just like any other child. And so the program for ensuring cardiovascular safety in this phase 3 program was very, very rigorous. In fact, I've heard that this is probably one of the largest longitudinal pediatric echocardiogram studies ever done, and it's being done in an epilepsy drug trial. So that's interesting. And there's been many cardiologists that have been involved as part of the data safety monitoring board along the way. And so echocardiograms were done every 6 weeks for 5 occurrences, and then spaced out to every 3 months. And then as we got further on, years down the road, we're spaced out to every 6 months. I'm reporting out the compiled data that we have as of March 2018. I know that seems a while ago, but you can imagine putting together all these data and being able to report on it does take some time. This included all patients that had received at least 1 dose of fenfluramine, and you can see the majority of these patients are on this, have been in this report out, have been on the drug for almost a year, with some 634 days, going out to almost 2 years. And there have been no cases of valvulopathy or pulmonary hypertension. And the most common finding, as we would have suspected, is this intermittent physiologic regurgitation. And this next slide really shows a figure. I don't expect you to follow all the lines here, but basically what this is trying to show is that each of these time points along the way, you can see that someone may go from absent to trace and then go back to absent. And there's no changes in the drug dosing in any of these patients at any time based on the development of trace regurgitation. So we were actually able to see very nicely that despite keeping the patient on a steady dose, whether that be low dose, high dose, this regurgitation sort of came and gone. That doesn't make sense, but you know what I mean. And was considered to be physiologic. And keep in mind that also includes patients who are on placebo, right? So we had patients with placebo that had normal absent regurgitation, developed trace, and then went back to absent again. And so while I don't have all of the compiled data, I did touch base with the study team, and I can tell you that as of today, there have been over 500 Dravet syndrome patients that have received fenfluramine in the various phase 3 programs or expanded access program, and still there's not been a single case of valvular heart disease or pulmonary artery hypertension. And that original cohort in Belgium many of them are still taking fenfluramine. So we do also have a small percentage of patients, small cohort of patients, I should say, that have been treated for upwards of 30 years and have also not shown any valvular heart disease or pulmonary hypertension. So this is, of course, very reassuring to me as a clinician who cares for these patients, certainly as an investigator in these studies. You go into these things not really knowing what to expect, but I think we were all very pleased to see that so far this has not been an issue. And then just the last few slides here, getting back to quality of life, right? So we've shown that this is an effective drug at reducing seizures. We've shown that adverse event profile is very much in line with other anti-seizure medications that are commonly used. That yes, there is going to be a risk mitigation program to ensure that echocardiograms are done to ensure safety, much like we test liver function tests in patients who are on valproic acid. And so we will be able to follow these patients. But how is this having an impact? So as Laura mentioned, it's got a different mechanism of action. Could this actually be a new pathway to explore not only in Dravet syndrome, but in other epilepsy syndromes as well? And this is something that a lot of studies are now using in epilepsy, this clinical global impression of change. It was initially constructed to look at outcomes in mental and behavioral health. And it's just a very simple Likert scale, 1 to 7. Both the clinician can assess the patient and say, okay, compared to the last visit, I think they're minimally better, or I think they're very much better. So it's subjective, but really a holistic sort of observation as to how that child is doing. And the parent is also asked the same exact question. And so you could have patients that seizures get a lot better, but they're asleep all the time, right? And so that's actually not a good overall outcome. Or you could have seizures get a lot better, but behavior goes off the rails. And that also would be a good outcome. But you could also have both. Maybe the seizures get better and you start to see some other improvements in terms of cognition and whatnot. And those might be the ones that get the very much improved. And so if you look at the scores that these patients were given by the parent, you can see that in the higher dose group, and again, this 0.8 milligrams, maybe there'll be a question about this at the end, but I'll just clear it up now. The FDA required the dosing to be expressed in terms of the base equivalent salt versus the acid equivalent salt. So the studies were initially done as 0.8 milligrams per kilogram per day, but the labeling is now 0.7 milligrams per kilogram per day. It's the same dose. It's the same dose of the active fenfluramine, but just for consistency's sake, that's why that's different. And you can see, again, a nice dose-related response here with only 10% of the placebo giving much improved to very much improved, 41% and 55%. So what is driving that? If we, again, look at the executive function, and I have a whole other slide set that I'd be happy to answer questions afterwards, but looking into this, there was this questionnaire called the BRIEF, which is a behavioral rating inventory of executive functions. It's a questionnaire that's filled out by the family. And it was filled out at baseline, it was filled out at the end of the study, and it was filled out even in the open label extension as well. And this was really put in there in the studies as a safety measure to make sure that cognition didn't worsen. But if you really looked at the results at the end of this study, you can actually see that scores that go down, and you can see there on the y-axis, if the scores go down, that represents an improvement. that actually the scores in the patients that actually were receiving drug, both at the lower dose and higher dose, actually improved. And some of these were actually highly statistically significant and actually clinically relevant in terms of how these scores are actually interpreted by neuropsychologists and people in the behavioral health field. So this is something that we're continuing to look into in more detail to see what is driving this. Is it all seizures? Certainly seizures are having a big impact on that, but maybe is there something where someone may be only having a 40% reduction in seizures and they're still seeing these improvements, maybe arguing that this mechanism of action could be having some positive impact on some of the non-seizure related comorbidities. And then lastly, before I conclude, is this all good? You're only showing me, Dr. Sullivan, you're only showing me 12 weeks out, and we know that 12 weeks is just a sliver of a patient's lifetime, and then what happens after 12 weeks? Well, thankfully, this is a figure from the open label extension study, and you can see that all patients that have been followed out over time here with this decreasing N is not due to dropout. Well, certainly there are some patients that have dropped out. The dropout is minimal. These reducing numbers are really just because of scattered enrollment into the open label extension compared to when they came into the pivotal study. And we can see that durable efficacy of 60–70% reduction in seizures does seem to be maintained in the vast majority of patients over time. Even if you look out here, this pretty good N of 222 patients at 1 year out. Really reassuring. So to conclude, hopefully I've summarized quickly the data and the primary outcome measures from the 2 randomized placebo-controlled trials that confirmed observations of just those small initial observations in the clinic, that there's robust efficacy in the reduction of convulsive seizures, with many patients having a 75% reduction in seizures. And for me, that's kind of my new bar. When I see a new patient with Dravet syndrome now, I still can't look them in the eye and say seizure freedom is a realistic outcome, but I say that I think we can now achieve or hope to achieve a 75% reduction in seizures, and we hope that maybe we do get these longer periods of seizure freedom. That despite the historical concerns surrounding the use of fenfluramine as part of the weight loss regimen, they're in adults at higher doses and combined with the other drug fenfluramine, that in our patient population at these doses, there so far has not been any concerns for cardiac valvulopathy, and that overall it's a well-tolerated drug with some observed improvements in cognitive function that we hope it remains durable over time. So with that, I will open it up for questions.
Wonderful. Thank you so much, Dr. Sullivan. That was a terrific review. I love that you shared the history of how drugs are tested and come to patients, as well as the efficacy and safety data. So very important. So now we'll begin our Q&A session. Again, if you have questions, please go ahead and type them in the Q&A tab at the bottom of your Zoom panel and send them on in. I know that there are already some questions coming in. We will do our best to get through as many questions as possible. So to start off, I was wondering if you could comment, Dr. Sullivan, on the scheduling classification. Now, some people may know that drugs are scheduled according to the FDA and DEA. So could you speak a little bit about that, and what classification did Fintepla receive, and what does this mean? Yeah.
So yes, the FDA has a Schedule 1 through 5 or unscheduled ranking system. Fintepla is a Schedule 4, which many new epilepsy drugs that come to market are Schedule 4. For me, in fact, I had to actually even look up in preparation for this what that actually means. Not to be selfish, but practically it means that that I have to actually I can electronically prescribe it, but there's one other little check because it is a controlled substance. And the reasons that go into that, I have to admit, are not, I still don't fully understand. The fact, though, that it is a central nervous system acting drug is something that certainly plays a big role in that. We don't necessarily there's no evidence to suggest that it has an abuse potential. And I would look at it as we do many other new epilepsy drugs that get approved by the FDA, both in the pediatric and adult space.
Great, thank you. And you've already alluded to this a little bit in your talk, but can you talk about other syndromes or epilepsy types that Fintepla may be useful for or is being tested for?
Yeah, great question. So there is a completed phase 3 study that has been, results have been released for in Lennox-Gastaut syndrome, which also showed efficacy compared to placebo. It wasn't as dramatic as what was seen in Dravet syndrome, but Lennox-Gastaut syndrome, for those of us who treat both these, we would all agree is very different syndrome than Dravet syndrome, with a lot of different background causes, whether it be brain injury, genetic, unknown. And so it wasn't necessarily a surprise to me to have a more heterogeneous, even though it's a homogeneous syndrome that is Lennox-Gastaut syndrome, the background etiologies are wide and varied, as opposed to Dravet syndrome, which is a monogenic epilepsy. Even though there are poor genotype phenotype correlations, maybe the more homogeneous your cohort is, you have a more ability to detect a significant difference in terms of seizure reduction. So Lennox-Gastaut syndrome, that trial is completed. My understanding is that Zogenix will be submitting for labeling for the use of Fenfluramine in Lennox-Gastaut syndrome. And I think that it definitely warrants additional study in terms of whether there are other epilepsy syndromes that this could be effective for. My colleague Elizabeth Teal has a small study that in sunflower syndrome that has also shown efficacy, again getting back to that self-induction link where these kids go out into the sun and they can self-stimulate. And so then you have 3 very different epilepsy syndromes. You know, it's very possible that that Fenfluramine could be a broad spectrum anti-epileptic drug with sort of these favorable or more enriched responder rates in some of these syndromes. And so I think it's our job as the clinical pediatric epilepsy sort of community to try and figure out what would be the next target syndrome to go after.
Great, great. That's really exciting. Along the same lines, there's a question that came in asking about medications that help kids who have seizures related to heat or rapid body temperature changes.
Oh, interesting question. So as far as, let me think about that. So we definitely know that patients with Dravet syndrome and SCN1A mutations do have temperature sensitivity. That's actually been well documented in animal models as well, where you can heat up a Drosophila with an SCN1A mutation and they have a seizure. And interestingly, this temperature sensitivity does tend to wane over time, whereas adults tend not to be as temperature sensitive. And in my opinion, Fenfluramine is not necessarily being effective in just those patients that have temperature sensitivity. So I think this may be something where, again, there's that enriched responder rate for Dravet syndrome, but that's independent of this temperature sensitivity. But it's an interesting question to ask as to whether or not there are other temperature sensitive seizure syndromes that may be a target. But in my practice, when Dravet patients actually have a fever, even though we have no evidence to support this, so again, getting back to the plural of anecdote does not equal data, we do try temperature reducing measures, and some kids we even try to give sort of benzodiazepines for 24 to 48 hours to bridge them through their fever. And again, isolated patients say yes, that's effective for my child, but that's not something that I recommend with every patient, and certainly don't have any scientific data to support those recommendations that I'm making.
Okay. So more to learn for sure.
Yes, absolutely.
Different populations of people. So another question, this person has a child that was not able to get into the trial because of minor regurgitation identified through an echo. Do you see any concerns after studies with starting Fintepla?
I really don't. And I think that's the nice thing to see that even in the placebo group, right, we saw this regurgitation. And so I want to stress, and this actually created some anxiety for some of our patients who did screen fail because they had this trace and oh, does my child need to see a cardiologist? The answer is no. And we've asked cardiologists this all across the country. Your child's heart is normal if they have trace regurgitation. And that should not be a precaution or for starting fenfluramine now in the post-study sort of commercialization phase. Certainly, the REMS program is there to follow this in exactly that way. We don't really see any signal to suggest that trace regurgitation, again, because it's a normal physiologic finding, would be a risk factor for the development of valvulopathy. But that's going to be followed over time, and is why I feel very comfortable that this REMS program is going to allow us to start this drug in more patients and follow that safety signal over time. That's
great. That's very encouraging, I'm sure. Another question. This is actually coming in from the UK, and it's asking about weaning off of phenobarbital, and would this be a better drug?
Oh, great question. So our goal is, seizure control and minimizing side effects and maximizing quality of life. So I think you'd have to ask yourself, how is your child or your patient doing on phenobarbital? Phenobarbital certainly gets a bad reputation, but it does work for some patients. And so I would say if the patient is doing whatever you determine is okay, then I would not rock the boat. Go with what you know. Because while fenfluramine was effective in the majority of patients, there are some patients where it's not necessarily going to work for. So I would caution about trying to do that. Now, if you're looking at if my my new bar is 75% reduction in seizures, if the child is still having a high seizure burden, you're questioning whether or not there are phenobarbital related side effects, whether suspected or confirmed, I think it would certainly be the right next step to add fenfluramine to that regimen. If the patient improves, then very, very slowly taper off some of the background drugs. And that's true for phenobarbital, that's true for valproic acid, that's true for any background drug. At least with my practice is if I'm adding a second or a third or a fourth drug to a regimen, I'm acknowledging that drugs 1, 2, and 3 are not getting that person to where they want to be. And so if I add in the newest drug and we see dramatic improvement, we then have to ask ourselves, is the majority of that improvement all being realized from the additional drug? And can I reduce background drugs? So unfortunately, I showed you that list of drugs that were in the phase 3 trials. Even though there were only 4 to 5 drugs that were the most commonly used, the number still, we cannot tease out whether or not there's like a combination that was more effective than others. And I think that we'll just sort of have to realize that as more patients get started on these over time.
Okay, great. Here's another question that's coming from the SYNGAP1 community, where there's a broad phenotypic spectrum, and many of the individuals with severe cases are they're being recommended to try fenfluramine. Is there a basket study? Is there consideration for broader testing across some of the rarer epilepsies?
Yes, so a basket study has been discussed and was sort of moving forward, and then COVID happened. I'm optimistic that the basket study will likely get restarted. It's still being figured out in terms of what syndromes, and this is always so hard, right? Because everybody wants their rare syndrome to be included. But that's certainly being discussed among the company as well as the pediatric epilepsy community that's participated in the trials so far and feel very comfortable with the drug. Okay. So sorry, that's an avoidant answer. more to come.
Yes, fingers crossed that we can get back to some of these many clinical trials that have been put on hold, can get back and be moving forward to help patients. There is another question. Can you just, again, reiterate the difference between hetero and homogeneous epilepsy types and how this treatment is more appropriate for one versus another?
Oh, sorry, maybe I shouldn't have, if I misspoke there. So I think there's just a question as to why was fenfluramine so good in Dravet, right? Is there something about the mechanism of action that we don't necessarily understand at this point that works with a patient with an SCN1A mutation? We haven't gone back and looked at those patients that did not have a mutation in the SCN1A gene to see if they responded as well. Just because of the numbers, it's probably going to be a small percentage of patients. So even if they did or did not respond as well, it's going to be difficult to draw any conclusions there. But I'm just thinking, just like, how can I explain it? Why is it better? I think that epilepsy already is such a heterogeneous diagnosis, and it's not until these monogenic discoveries that we're able to really get into the specific phenotypes and have hypotheses as to why these even translate into seizures and the non-seizure related comorbidities. And so I was just speaking that from a study perspective, the reason why there may have been a disparate responder rates between Lennox-Gastaut and Dravet may just because you have a more homogeneous background. So it may be possible that if you took patients with Lennox-Gastaut of unknown cause and excluded all patients with Lennox-Gastaut that had a history of infantile spasms, maybe, again, I have no idea if this is true, but maybe those patients actually would have responder rates that were closer to patients with Dravet syndrome or vice versa. So there's just a lot of background. Already there's background genetics in even an SCN1A, right? But you take something that's not monogenic and has all these other different causes, that's just my hand-waving explanation.
Okay. So one final question that a couple of people have asked are patients on Fintepla also on Epidiolex?
So yes, so as part of the phase 3 programs, Epidiolex was not yet FDA approved. So any other investigational drug was not allowed in the double-blind placebo-controlled trials. And then even in the open label extension for the first 6 months, we really, per the protocol, couldn't make any changes to background medications, specifically additions of drugs, because then that actually really confounds the open label extension data. But then it just happened to align that as once Epidiolex was approved and we had more patients in the open label extension, and again, even if you were considered one of those super responders and had a 75% reduction of seizures, if you were still having seizures, the investigators did have the ability to ask the medical monitor for permission to start the drug. And now in the expanded access program, I certainly have a handful of patients who are on both. It's still been a relatively short period of time for me to be able to say, with confidence, like, how is that combination actually working? It seems at first glance to be well tolerated. There does not seem to be significant drug-drug interactions. But I do think, ask me that question a year from now, and I think it's going to be exciting to report back whether or not we can see these incremental benefits of 2 drugs that have good phase 3 controlled data to support their use in these patients.
Okay, so more to come and more for us to report out on next year, I'm sure. So with that, I want to thank you, Dr. Sullivan, for providing such a terrific talk, great overview, and for the time you took to answer questions. I'm sorry we're not able to get to them all. I also want to thank Zogenix for allowing us to present this exciting opportunity. I really am excited about how this can help our patient community, and so I appreciate their willingness to let us share the story. I'd also like to thank you, our audience, for asking great questions. If you have additional questions about the topic or wish to learn about any of CURE's research programs or future webinars, please visit our website at www.cureepilepsy.org. Also, please be sure to register for our next CURE webinar that will address an issue that many families are concerned about right now with the current pandemic, and that is specifically respiratory physiology and seizures. In fact, our CURE grantee, Rup Sanju, from the University of Iowa, will discuss research surrounding respiratory dysfunction and seizures, as well as potential cause and biomarkers for sudden unexpected death in epilepsy, or SUDEP. This webinar will be presented at 1 p.m. On SUDEP Action Day, which is October 23rd. So stay tuned for that. Please do register. Thank you again for your time. Thank you to Dr. Sullivan, and please everyone be safe.